Thank you very much, Bob. Hello, everybody. And I also did not prepare my slide for disclosure, but I have some relations for unrestricted funding by Nestle, but I will not talk about nutrition. So in order to make this clear. So I thought when I was asked to give this neonatologist perspective, and ISMRM is usually a little bit, you know, nobody quite knows why you would want to be interested in the newborn, and especially in the prematurely born newborn. So why would that be so important? So I thought I'd give a little bit of an introduction into that as well. So let's see. So why would we be interested in how early life events change our lives forever? So you can either be born like this little guy prematurely and then have these little tubes sticking into your nose and into your mouth in order to be fed and in order to get supplemental oxygen, or you actually can be in this condition where your mother doesn't have enough supply through the placenta, and again you also are deprived of nutrition and probably oxygen supply at some stage. And these two conditions can actually affect your development. And so to give you a little numbers and maybe make you aware why it is important to study these conditions, is that of the 120 million babies born every year, there are about 5 million term-born babies that have this condition that the placenta isn't supplying them with enough nutrients and oxygen. And so there's a huge number of people every year that undergo this condition. And then if you go up the pyramid and you go to the babies born prematurely, you can see that there are indeed about 1.6 million babies born quite prematurely between 28 and 32 weeks, or slightly under a million born below 28 weeks, so below 7 months of gestation. And you can see that these are then associated with quite a bit of morbidities. And somehow I don't do this right, I guess. This is what I want to do. We have a large proportion of these children that will actually develop moderate to severe long-term disability. And this is, of course, a huge loss of human capital, because these are the children that will either not be able to follow normal schooling, or then at least need to have treatments and support and learning difficulties, and not attain their maximum cognitive potential. And so this is a huge problem, and therefore we need to understand more how these things are affecting the survival and the well-being of these children. Another big issue with preterm birth is the high risk of associated morbidities. And in recent years, people have come up in different population studies showing that actually the prevalence of having a psychiatric disorder later in life is really increased by premature birth. You can see it's about a threefold increase or fourfold increase in any disorder of psychiatric type in children born preterm. The ones that are most prominent are ADHD, but also autism, and then some more in the conduct and in the emotional regulation and interpretation. So there is a high link to the massive increase of neuropsychiatric disorders that our world is seeing. In Europe, we estimate that about 27% of the populations have some kind of mental disorders. That's really a scaring kind of number. So why then, so how can we dig in and understand what an event that occurs so early in development has such dramatic lifelong consequences? And that, of course, brings us back to the sort of neurodevelopmental events in cortical histogenesis. You might remember from anatomical classes that the brain sort of starts in the first trimester with the cellular specification, proliferation, and migration of neurons. And then in the late fetal and early neonatal life, we have the sort of aggregation of cytoarchitecture with the neuronal dendritic differentiation, the axonal outgrowth and sort of establishment of the brain connectivity, and then in parallel also a sort of overgrowth which then needs to be pruned to be efficient functionally. And in parallel, in the late fetal and early postnatal life, myelinization or myelination starts, where our system gets efficient for signal transduction. You can see that many of these processes are experience independent, but when you come to the later fetal period and the early postnatal period, then they get sensory sensitive or sensory driven. So actually what these babies experience over the first weeks of their life might actually affect how their brain is going to be wired. And that's why it's so important to know how these brains are wired. So let's just talk a little bit about these connectivity establishments in these early periods. So you can see that between 20 and 24 weeks of gestation, so this is sort of the time point where the earliest preterm babies nowadays survive. The axons, both in the projection, commissural association fibers, are growing actively in the periventricular white matter regions. The thalamic projections are still sort of waiting in the subplate. This is the zone underneath the cortical laminations. And then between 24 and 32 weeks, these thalamocorticals leave the subplate and enter the cortex and contribute to the final organization of the cortical lamination. In parallel, the callosal or commissural fibers enter the subplate and then go into the cortex between 32 and 36 weeks, where the subplate layer then gradually decreases and disappears completely by about term age. You can see also these two zones of the subventricular zone and the gray eminence where neurons can still differentiate and migrate, and most of them are GABAergic interneurons that either radially from the subventricular zone or tangentially initially migrate still during this late fetal period, and that's a great potential for plasticity, but of course also for alteration of the later inhibition network that we are so dependent on, especially in the context of psychiatric disorders. So what happens if these babies are born preterm and are exposed to either hypoxia, ischemia, infection, inflammation, deprivation of nutritional support, deprivation of growth factors? They can have various signs of focal lesions, such as the destruction of the germinal matrix in the context of intraventricular, periventricular hemorrhage. They can have a focal or a diffuse white matter injury, which we neonatologists called periventricular leukomalacia, where we have a necrosis or an apoptosis, in part, for example, early described of the immature oligodendrocyte, the cell that produces myelin, for which we then find hypomyelination and also a gliotic reaction. These then actually lead to neuroaxonal disturbances and alterations in the cortical organization. And you see this in this diagram that Joe Volpe, a main neonatal neurologist from Boston, has put together in really sort of, for us as imagers also, to sort of think along the line, what are the injuries that are occurring during this time period. So you have the direct axonal injury, you have injury to the subplate neurons, you have injury to these oligodendrocytes that are maturing, and you can have injury directly to the thalamic neurons. All these can lead to decreased myelination, but also to cortical and thalamic development alterations, which of course then alters the overall connectivity. So with this in mind, we want to have imaging biomarkers for all these kind of processes. So injury to these particular areas, injuries to the cortical development, and then the subsequent consequences such as delayed myelination and alteration in brain connectivity and function. So you see that the evolution of studying the babies with MR has been around for a while. You see I've aged a little bit. This was taken 1989 back in Bern when we started to study the first MRs in Bern. And this is actually one of the plenary speakers of Wednesday, Chris Bush, with his baby or children MR scanner about at the same time point. And you can see that this has been around, and we've developed these techniques from swaddling babies like that into a normal adult head coil to the now incubator MR compatible with a dedicated newborn coil, which permits us to really study the newborn brain, but also other areas of the body that, of course, cannot be part of my talk today because of time constraint. So when you look at what we can do with MR in the newborn, we can look at macrostructure, we can quantify macrostructure, we can look at microstructure, quantify microstructure, we can look at metabolism, quantify metabolism, and finally we can also look at function within the newborn brain, and even at resting state functional connectivity in the newborn brain. To show you a little bit how images correlate with functional maturation, just these images where you see the tiny little bit of myelin which is present in this preterm T1 weighted conventional image that then grows in the corticospinal tracts here with the myelin deposition around term age to 1 year. And you can see how this actually changed the motor control of the preterm infant, which has no flexion extension control, the term newborn that has this nice flexion extension control, and then the 1-year-old that finally starts to be able to control his movements and to have some precision in the motor action. What happens when things go wrong? When things go wrong, then you end up with some of these focal lesions. Here you have a huge ventricular dilation as subsequent to a hemorrhage, or you have an alteration of the periventricular white matter with a necrosis in these areas, which is the typical form of periventricular leukomalacia. These two conditions have, of course, been described in the last centuries by neuropathologists, but it's only imaging that has allowed us to actually in vivo observe these changes. One way with the bedside technique of ultrasound, where you see these aspecific hyper-echo densities, or then with MR imaging, and in particular with diffusion-weighted imaging, here the ADC maps, which show an acute phase of periventricular leukomalacia, which you could probably sort of similarly see in a stroke patient when you have not seen baby images. The evolution of these changes, of course, are that you can measure your ADC. You have to be aware of the fact that the apparent diffusion coefficient levels in a newborn are much higher than for an adult. So a 0.6 would be a highly abnormal ADC value for the white matter, which usually has a normal value from about 1.6 to 1.5. That is then the chronic stage of this periventricular leukomalacia, where you see the loss of white matter with cystic formations and gliotic scars around it. So this is the classical way of characterizing an acute focal lesion. When you see a more diffuse area, then you can see that actually there is alterations in the white matter in a more diffuse pattern, and this was actually called the diffuse excessive hyperintensive white matter that people often observed in these very early born preterm infants. And for some of them, when they died, you could see that these tissue was actually full of macrophages, loss of axons, and pycnotic cell death, so apoptosis going on. In more recent times, where people have to overquote this diffuse extensive T2 hypersignal and found 50% or more babies having that, people could actually show that there is not a very good correlation to neurodevelopmental outcomes. So you have to be very good in assessing these kind of changes. And one way of doing that is you can use these classification schemes that have been developed for the preterm infant specifically to sort of look for the changes that are signs or biomarkers of this encephalopathy of prematurity and then grade them into non-mild, moderate, or severe. And you can see that they actually do represent neurodevelopmental outcome, for the severe and moderate cases being clearly below the normal and the standard deviation, whereas for the mild, you're just at the border of the standard deviation for the main neurodevelopmental outcome measures at 2 years of age. This also holds true even later, and that is what I said in the introduction. These changes really have consequences throughout childhood and maybe into adulthood. These same classifications of white matter abnormalities were actually significantly correlated with neurocognitive deficits, specifically for executive functions and also intellectual delay. But we have to go further. We can't stop with these scoring systems, because in the introduction I told you that these pathways, these periventricular pathways, these thalamic cortical connections, they have these crossroads here in the periventricular white matter, and we still don't have a good way to actually classify in the acute stage how these thalamocortical pathways, if they are intact or altered in the acute setting. So that is something we need to further develop. We need to also be able to quantify, are these differences important? Are they mild? Are they moderate? How do we quantify the difference if you see an MR that this has this kind of aspect versus this one? They should be the same, but they are kind of not the same, but how to quantify? And there, of course, you will hear more about this by Simon Warfield, who will talk after that. But some 10 years ago, we started to develop segmentation tools for these MR images to actually quantify the white matter, the gray matter, the myelinated white matter. It's a very specific difference to have the myelinated versus non-myelinated white matter, and this poses quite some difficulties for these signal intensity-based algorithms. But with the development of these tools, we were able to show that many areas, and not just the white matter, but also the cortical development, is affected by prematurity, also the cerebellum and certain areas of the basal ganglia. So when we now come to the fact that we wanted to look more into connectivity, then of course we can already identify white matter connectivity in the newborn, even though these white matter tracts are largely unmyelinated. These are data, for example, from the corticospinal tract in the newborn. And you can see that there are distinct quantitative differences in the classical FA and the radial and axial diffusivity markers between preterm and full-term infants along the corticospinal tract. So you can see that the preterms are always, in a sense, more immature in the characteristics of these long projection fiber systems. We now have techniques in DTI that can go deeper into microstructures, such as NODDI, the neuro orientation dispersion, density indexes, and diffusion imaging, where you can sort of not only look at the usual radial and longitudinal diffusivity, but you can do it more in a compartment way, where you say you have water diffusion that is intracellular, so for example in the intraaxonal volume, whereas the extracellular, whereas the ventricular or CSF, which gives you a three-compartment model which better characterizes the microstructure tissue and lets you also sort of look at the effects of dispersion, not just of actual axon density. When we do this over the developmental period, you can see that certain characteristics, for example, for the cortical corpus callosum, which shows the highest FA and the highest intra-axonal volume fraction. Similar then to in the plic, where we have a significantly higher in the posterior than in the anterior, consistent with differences in myelination at that time, and then the more frontal and uncinate fasciculus that show the lowest intra-axonal volume fraction and the highest dispersion index. So these are new ways to look at changes during development, and what you can see here from the preterm to the full term, you can see that, for example, the intra-axonal volume fraction shows this developmental trend in increase, whereas the FA in the corpus callosum does not show that. So you start to pick up things that are separating fiber orientation and fiber maturation. So these things really, what I try to illustrate to you, shows how the cortex gets organized. So the cortical surface is then primarily driven by the number of the cortical laminations, the cortical layers here, whereas the thickness can be defined by the horizontal areas. So when we look at the imaging of the preterm babies from birth to term equivalent, you can see these dramatic changes in surface and sulsation index that occur with the folding of the cortex during this time period. And of course, any disturbance of these cortical foldings, like fear, for example, when we take preterm infants that had these abnormalities that I've shown you on conventional imaging, you can see that the frontal sulsation index is altered in these children. And that can well be linked to a change in cortical thickness and in cortical organization, which then relates to capacities, for example, early attention in the newborn period. When we look at these things, then we want to be able to look at the connectivity atlases and the connection matrix, and we would like to know, is this brain of a preterm infant actually normally organized? Do we have a respected network topology? And if you've been to the diffusion education course, you've heard a lot about the graph model analysis, which is a mathematical approach to characterize such a complex network, where we can look at average strengths and global efficiency and local efficiencies. When you do this and you compare extremely preterm infants to control preterm infants, not even full-term babies, you can see that many of these global network measures are clearly significantly different. When you look over time here, for example, babies that have undergone this poor nutrition in the fetal period, you see that the network organization of an IUGR-born preterm infant at 1 year of age compared to a control is quite different, and that this difference persists at 6 years and 10 years but becomes less evident. So there is some inherent plasticity that we, of course, need to understand more. When we look more regionally, then we could show in a study in 6-year-old children born preterm that the networks that were particularly altered, so if you go to regional networks, were the frontal networks, but also the links of the corticobasal ganglia thalamocortical loop. So these thalamocortical fiber networks that connect to the frontal lobe are the ones that are most changed at 6 years, and they actually correlate well with problems in hyperactivity in attention, but also social resolution tasks. So the two networks that were particularly altered are these networks from the dorsolateral, prefrontal, lateral orbitofrontal cortex, and the limbic and the paralimbic cortex, including the amygdala, which is also reduced in volume in preterm infants. So clearly these are the links to the potential later neuropsychiatric disorders. And what you can see in this sort of gender-specific attention subsystem network vulnerability is that the boys are even more vulnerable than the girls. So there's clear interactions for these kind of alterations in the core connections. When you look at the brain network organization overall, what these analyses illustrate is that there is a reduction in modularity in the extremely preterm infants compared to the control infants. And that, of course, then can really lead to a different network community structure. So just 2 words to the BOLD signal, which you all, of course, know. In the adult, we all search for this loss or reduction of deoxyhemoglobin that stands for an active area. We know from adult studies that indeed the excitatory and inhibitory activity and the influence of anesthetics might have this initial negative dip for the BOLD response. But how about in the newborn? Well, in the newborn, your BOLD response can be completely different. It can be completely negative, so this is an event-related response to visual stimulation, and you have a negative BOLD. So you actually have an increase of deoxyhemoglobin rather than a decrease. And that sort of illustrates how much in the neonatal circulation, the circulation is very much dependent on blood volume, blood pressure, and you can see that if you have a lower blood pressure, you actually have a negative BOLD, whereas if you have high blood pressure, you have a positive BOLD. So the newborn needs to be addressed particularly, and this also holds true for some resting state networks that you can see in the newborn, very similar to the adult, even in these preterm infants. And then you can see that some of the networks in the preterm, for example, the salience network, is very much different than the adult network and the full-term network. And when you think about the salience network being very much linked to the expression of synaptic genes, then we come back to this sort of sensory-driven modulation of these networks early on that could well be at the origin of these neurocognitive deficits. So I tried to show you in this introduction that really it's important to learn about the brain, the interrupted brain of the preterm infant, and we have to use our imaging biomarkers to learn more about how these brains are interrupted and how we can connect them more together. I would like to put up this final slide in encouraging you all to help us solve the problems in MR imaging of the developing brain. I put some of them up. We need higher image resolution because the cortex is only 1 millimeter thick, and there are 6 distinct cell layers that we're interested in. We want to know about cerebral lamination. We might need new contrast, for example, the phase readout, to look at the separate content of extracellular matrix. We need to finally learn more about diffusion imaging yet again, because we do not know exactly what FA and intraaxonal water fraction mean. And for the fMRI, I think we need to learn more about the specific hemodynamic response in the developing brain in order to understand fully the functional response and resting state functional connectivity in preterm or newborns. And with that, I thank you and hope you come all to human brain mapping, then that's what you will see there. Thank you.